Greetings, ladies and gentlemen. This is Dr. Muhammad Khan, one of the internal medicine resident at Orange Park Medical Center, and I'm going to present a case of marijuana-induced reversible cerebral vasoconstriction syndrome. I would like to thank Dr. Ghafourian, Dr. Khalil, and Dr. Chaudhry. Starting with the introduction of this syndrome, it is basically suggested as an amalgamate term for multiple similar syndromes, including Gall-Fleming, benign angiopathy of CNS, and drug-induced cerebral arteritis or angiopathy. Although definitive etiology is unknown, most of the cases are secondary to use of vasoactive substances like SSRIs, cocaine, ecstasy, and marijuana. So, starting with the case presentation, we had a 26-year-old Caucasian female with a past medical history significant for hypertension and polycystic ovarian syndrome. She presented with sudden onset, progressively worsening right-sided headache associated with blurry vision, photophobia, right hand numbness, and ataxia for the past 6 to 8 hours. She reported having similar symptoms 1 month ago, which resolved spontaneously. Social history significant for 10-pack year tobacco smoking history and marijuana use for the past 6 years. Her initial NIH stroke scale was 3. Neurological exam was as follows. She was alert, oriented times 4, normal speech, extraocular movement was intact, cranial nerves 2 to 12 were intact. She had right lower quadrant homonymous visual obscuration with retained fields, right arm pronator drift, and rest of the exam was within normal limits. Initial urine drug screen was only positive for cannabinoids. A brain CT on arrival showed edema of the gray and white matter in the posterior frontal parietal and superior occipital lobes. A subsequent CT angio of the head revealed severe stenosis of the left distal M1 and proximal M2 segments of the middle cerebral artery with multifocal infarcts in the MCA territory, as shown in the figure 1b. A brain MRI showed multifocal punctuated regions with a restricted perfusion predominantly in the left parieto-occipital and left frontal cortex. She underwent cerebral angiogram, which revealed focal flow-limiting stenosis measuring 83% of distal left MCA, as shown in figure 3, consistent with RCVS. The patient was discharged on verapamil 80 mg TID, and her symptoms improved over the course of the hospital stay. As for the discussion, basically the diagnosis is based upon the characteristic clinical brain imaging and angiographic features. Recurrent thunderclap headache and single thunderclap headache combined with either normal imaging, border zone infarcts, or vasogenic edema have 100% positive predictive value for diagnosing. Researchers have developed a score for diagnosis known as the RCVS2 score, and any score greater than or equal to 5 have a high specificity and sensitivity, 99 and 90% respectively. Imaging plays a critical role in the diagnosis and management. They usually use non-invasive techniques such as MR angio. The management options include calcium channel blockers, for example, nimodipine and verapamil as given to our patient. And in some studies also showed that dantrolene have been also used to alleviate the vasoconstriction. As far as the prognosis is concerned, 71% had no evidence of disability and 29% had only minor disability. I would like to end my case presentation here. Thank you so much.